Thanks everyone for joining us. I am Carolyn Spath. I'm the Director of Community Outreach here at National Kidney Foundation of Wisconsin. And we are so proud to partner with UW Health Transplant Center, as well as Living Donors Together of Wisconsin, in hosting this joint meeting webinar today. So for those of you who are used to the Living Donors Together of Wisconsin format, we are changing it up just a little bit today. We're going to keep everyone's camera off through Scott's presentation, and then after the presentation is over, we will encourage everyone who wants to stay online, turn on your cameras, come off mute, and share any normal Living Donors Together of Wisconsin business that you might have, any topics that might be weighing on you that you need to discuss with the group at that time. In the meantime, please use the chat feature, use the Q&A feature to drop questions in. I'll be coming on at the end of Scott's presentation to moderate some questions for him that way. And I hope that we have a great presentation. So Scott Johnson is with us today. He is a manager in living donation with the UW Transplant Center. And I look forward to hearing what he has to say. Take it away, Scott.
All right. Thank you, Carolyn. I would say good afternoon, but for me, this is starting to be evening. I'm a bit of an early bird, so I will say good evening. Thank you so much for having me. As Carolyn said, my name is Scott Johnson. I am the manager of living donation at UW Health in Madison, Wisconsin, and that is the manager of both the living liver and living kidney donation programs. Of course, we're here to talk about kidneys, so we will talk about kidneys tonight. A little bit about my background. My training actually is as a nurse practitioner, and I've worked at UW in all aspects of transplantation for about 16 years. About half of that was as a nurse in various areas, both heart and lung transplant, the cath lab, the heart ICU, the heart and lung transplant ICU. Then I decided to make my life more complicated and go back to school, became a nurse practitioner, and I started practicing in transplant surgery down in our clinic with our kidney, pancreas, liver transplant programs. So I really have kind of worked all across different areas of transplant. It's been sort of my passion since graduating college, and it kind of feels like home. So I've not left, and I'd be hard pressed to leave transplant at this point. A couple of years ago, I did transition over into more administration. And as I said, my current role is as manager of the Living Donor Program. So tonight, I hope to take you on what I call and what we tend to call a living donor journey. We lovingly refer to it as a journey, as many of you understand that, and the rest of you will hopefully understand that after my presentation. So let's get going on our journey. So just a very brief background about kidneys. We should have about two, although we should have two. I have met a few people in my life, diagnosed them with one kidney and diagnosed a few with three kidneys, believe it or not. We really should have two kidneys in our body. They live kind of tucked nicely in our back, underneath our rib cage, and they are incredibly important organs in our body. I think most people know or understand that they make urine out of a lot of our waste products, but that's really kind of just the tip of the iceberg. Our kidneys do quite a bit. They create hormones, probably most importantly, hormones that help us grow, hormones that help us regulate our blood pressure, hormones that help us produce red blood cells so that we're not anemic, and hormones that actually help us to create some more nutrients in our body, such as calcium and potassium. So our kidneys tend to be a lot more than just urine producers, although that obviously is a huge function of it. They're vitally important organs, and we tend to be able to function with just one good functioning kidney. But we are thankfully born with two, a backup that really gives us sort of a safety net, if you will. But that safety net is exactly why we're here to talk tonight about living donation, because we do. We have a safety net, and most people safely give one up. So a little bit about chronic kidney disease. Approximately 37 million American adults have chronic kidney disease. Now, chronic kidney disease, I don't just mean end-stage kidney failure, those folks who are on dialysis. I do mean any stage of chronic kidney disease, which you can see below, ranges from stage 1 all the way to stage 5. And that stage 5 is that end-stage renal disease where you probably need to be on dialysis. Kidney damage occurs typically over time. It can be either a very fast progression in some situations and some illnesses. In many situations, it is a slow progression from stage 1 through stage 5 and really ending up on dialysis. It probably is no surprise that the two main causes of kidney disease in Americans are diabetes and high blood pressure or hypertension. Those two disease processes are very much, unfortunately, popular in America and continue to be on the rise. So again, not so surprising that those tend to be the two main causes of kidney failure. As far as those folks who do end up, unfortunately, in kidney failure, there are two real treatment options for end-stage kidney failure. You can go on dialysis, in which case you do have options, or you can try to get a kidney transplant. Dialysis options include hemodialysis, whether that's in center or at home. It also includes peritoneal dialysis, where you actually use the cavity in your stomach as your dialysis machine, if you will. You insert fluid, you tend to let it exchange across the membrane of your stomach, and you can actually pull the fluid out then. That tends to happen every night, whereas hemodialysis tends to happen in center, usually 3 days a week, or you can do it at home. Some people, where you are doing that anywhere between 3 to 6 nights a week. So it's really based on sort of your life and what's going to hopefully work the best for you, as much as dialysis can work for you. As anybody who knows folks on dialysis, it is definitely not something that tends to work well in one's life or lifestyle. So hence we have the other treatment option of transplantation. And I'll go through that obviously in a little bit, but transplantation tends to be a far superior option for many, if not most people. Believe it or not, we don't tend to take out the old kidneys at the time of transplant. The rule of thumb is we always add, never subtract if you can help it. Now, sometimes we do have to subtract the old organs, but most of the time we're just adding that third new kidney inside of somebody's body. And as you can see on the right side of my slide, we don't actually place the kidney up where the old kidneys are. There's really not enough room, and getting up into that chest cavity area is pretty risky. So we actually have this really convenient, relatively low risk hip pocket, if you will. I love calling it a hip pocket. Down below, and we actually attach the new kidney to the leg vessels, the artery and the vein which drains and feeds the blood supply to your legs. So that kidney is actually kind of tucked nicely in that hip pocket, and it's well protected in front by your abdominal muscles and by your hip bone from the side and the back. So, you know, I think a lot of people hear that and they think, well, am I going to have this kidney just sort of tucked neatly underneath my skin and have this bulge almost like a goiter or a tumor? Not at all. It's very well protected and virtually unnoticeable other than a scar on the abdomen. So it is well protected where we would like to put it. Well, in the US, there are currently over 90,000 people waiting for a kidney transplant. It's actually, I looked it up just to get the current number, and it's around 96,000 people waiting for a kidney transplant in the US. There's a little over 110,000 people waiting for organs, period. And not surprisingly, 96,000 of those 111,000 make up kidney transplant waitlist folks. So kidney transplants definitely is the #1 reason why people aren't on organ transplant waitlist. And there's really two different types of kidney transplants. You could get a kidney transplant from a deceased donor, or you could get a kidney transplant from a living donor. And obviously we're here to talk about those living donor kidney transplants tonight. And I always like to say that kidneys from a living donor tend to work better, tend to work faster, and definitely tend to work longer. You're going to probably find people on the wait list for 3 to 6, maybe even 7, 8, 9, 10, 11, 12 years, depending on which center they are waiting in. Now, if you're waiting at a transplant center like Chicago or New York, you're definitely probably going to be waiting close to a dozen years for a deceased donor kidney transplant because there's a lot of people in those areas. Thankfully, in Wisconsin, we tend not to have that issue. And at least at UW is what I can speak to. We tend to have some of the shortest wait times in the region, just because we tend to transplant folks a lot, and we don't have that highly populated area like Chicago does. Now let's talk about those living donor kidney transplants. Like I said, they work better, meaning they give you better kidney function after transplant. They tend to work faster, meaning as soon as we plug them in during surgery, they tend to wake up and start producing that urine. And they tend to work longer, usually twice as long on average. Deceased donor kidneys tend to last anywhere from 9 to 12 years on average. Certainly can get 20 plus years with a deceased donor kidney, but the average is about 9 to 12. Living donor kidneys really should last 20 plus years. I think during COVID, we celebrated a woman who was on 35 years with her kidney transplant. And just last year, we celebrated somebody who was on 45 years with their same kidney transplant. So it is definitely, hopefully, a decades-long treatment for people. Now, kind of the fun stuff. Who can donate a kidney? Well, back even 10 years ago, we really were interested and focused on that match. We tend to talk about matches a lot. Do I match my intended recipient? How good of a match do we have? Matches are not as important anymore for a number of reasons, which we'll talk about later. But I like to say that as long as somebody is healthy enough and willing enough to be a kidney donor, we can make it happen. The match, again, is less important. So the person does have to be at least 18 years or older and generally in good physical and mental health. Now, what constitutes good physical and mental health? A lot of things. And that is really centered specific. So what we decide or what we have as criteria for living donation candidates at UW might differ slightly than somebody at Froedtert, than somebody at NYU, than somebody down in Birmingham, Alabama, because each center determines their own selection criteria. It is based on the overarching criteria set forth by UNOS, the United Network of Organ Sharing, sort of the overarching governing body of transplants. But each center can take those guidelines and sort of specify specifically what their center is willing and not willing to do. So we'll talk through that a little bit more. Now we'll start at the very beginning of our donation journey with referral. We'll talk a little bit about the evaluation itself, talk about donation, the surgery, talk a little bit about follow-up, but then I really want to focus at the end of what are those options? When I said earlier that as long as you're healthy enough and willing enough to donate, we can make it happen. We'll talk about what exactly that means and what options those living donor candidates have these days, and it is quite a number of options. So we'll spend a little bit of time on that, and then we'll talk at the very end about how folks could find a potential living donor. It doesn't just have to be family members or friends. We can really, with the advent of the internet, reach a lot of people these days and find living donor potential candidates anywhere. So let's start with the phase one, the referral. The referral, and again, this is really talking from a UW Health perspective. In general, you need to fill out the online application. That's how we get all of our living donor candidates started at UW. That is called the DASH form at UW, and that stands for Donor Automated Screening and History. That main website is uwhealth.org/canibeadonor. That is where all of our donor candidates must go to start their application. How somebody gets to that website, they can go through a few different means. They can go directly to that website. They could get there through the National Kidney Registry, or the NKR, which we'll talk about a little bit later. They could go there through a microsite through the NKR, or they could be transferred from a different center's DASH intake tool. I would say about 87% of our donors start their application through our personal DASH form at UW. It is really a form that goes through a lot of different questions. Their age, their medical history, their surgical history, their family history. Do they have a family history of kidney problems? Do they have a family history of cancer? Do they have a personal history of cancer or heart disease or kidney disease? Now, the DASH form was really built to be smart, and it does actually automatically rule some folks out. Let's say somebody says, yes, I've had 5 episodes of kidney stones and I have high blood pressure that I'm on 2 blood pressure pills for. That DASH form is probably going to rule that person out for us. In general, the DASH form rules about 30% of our folks out for us just because of these pretty hard and fast rules or red flags that we give that DASH form. So it is a pretty intuitive and intelligent system. But assuming somebody makes it through that, we then get that referral into our system at UW. And before we actually start to contact that donor candidate ourselves, rules by UNOS say that they really need to be contacted by an ILDA first. And when I say ILDA, it means Independent Living Donor Advocate. And these folks are professionals who are independent of that transplant center. So we hire these ILDA folks, but they don't work for UW Transplant. They work for a third-party company. And that's very important. That's a policy, because we want these donor advocates to really feel comfortable blowing the whistle, if you will. They're there to make sure that the donor candidate is advocated for, is comfortable with proceeding, is well informed and understands exactly what they are looking to get into, both with the evaluation and the surgery. And we really loop them in as a close colleague in our transplant center. But again, they do work outside of our transplant center and independently. And that is a very important policy that we follow. So that patient, that donor candidate, really needs to be contacted by them first. That ILDA will do a pre-screen call with that candidate, and they make sure that they are educated on what this means. They make sure that there's no coercion, that this donor candidate is not being paid potentially to try to donate an organ to somebody. This should be done of their own free will, and that's what that donor advocate, that ILDA, is there for. So once they complete that pre-screen phone call, they are letting us know at UW that they passed the pre-screen phone call and it is okay for us to proceed with our component. Now, our component really starts after that ILDA phone call. The nurse coordinator, the transplant coordinator on our team, will then contact that donor candidate and do a pre-screen phone call ourselves. That pre-screen phone call really lasts approximately 1 hour. And that's where we tend to review a lot of the donor candidate's health, medical, surgical history. We take notes on their allergies, of their current medications. And really, we're then spending a lot of that 1 hour phone call educating that person, educating them on what living donation actually means, what the surgery is. Believe it or not, we've had a few donor candidates think that they could donate their kidney through a simple blood draw. And I don't say that to make fun, but I say that to just raise awareness that there's a lot of misinformation out there and a lot of misunderstanding. So a lot of our 1 hour pre-screen phone call is spent just educating folks about what exactly this means and what the process is going to look like. If they pass that phone call and there's no other obvious red flags that may rule them out, we then schedule their evaluation in person. Our in-person evaluation happens, of course, at UW Hospital in Madison. It tends to include laboratory testing, so blood tests, urine tests, including a 24-hour urine collection, some diagnostic studies. And when I say that, I mean there's a chest x-ray that's done, there's a CT scan of those kidney that is done, and there's an electrocardiogram. Definitely, those are all the things that have to happen with every donor candidate evaluation. And then there's also other tests that may or may not be scheduled based on that person's health history. Maybe they are over 60 years old, and therefore we should get a stress test and an echocardiogram, a better picture of their heart, if you will. That CT scan that we do of their kidneys is really going to help us mainly decide if they are approved for donation, which kidney would we want to take? Would we want to take their left kidney, or would we want to take that person's right kidney, and why? Now, about 75 to 80% of the time, we like to take the person's left kidney to donate. And there's really a few reasons for that. The left kidney is easier to get out. It's a little more free, if you will, of some of the surrounding vital organs. And the vein that is attached to that kidney that drains the used blood is a lot longer than the vein from the right kidney. So that longer vein from the left kidney is somewhat helpful in the donor's surgery. It's very helpful in the recipient surgery. Think of it like an extension cord when we go to plug in that kidney to the recipient. That longer vein is much easier to then plug into the recipient when we go to transplant it. So again, we do this CT scan to make sure that, is it the left kidney that we want to take? Or is there a reason we might not want to take the left kidney? Maybe the right kidney has a cyst. Maybe the left kidney is a little bigger than the right kidney. If the kidneys aren't equal, if there's a lesser quality kidney, if you will, we tend to take the lesser quality kidney and give that for transplantation. We always want to consider the donor's health and risk to the donor when we're doing donation surgery. So if there's a bigger kidney, we tend to leave that donor with that kidney. We would never want to leave them with something undersized, too small, risking that maybe it's not enough for them. And then, of course, the last phase, which is the bulk of the day of the evaluation, is that those donor candidates meet with the entire team, one of our transplant nephrologists, one of our transplant surgeons, our social worker, our nutritionists, and their nurse coordinator, of course. Sometimes we have them meet with health psychology if there's a few, maybe a mental health concern or two. But all in all, it is a very full day. It's about an 8-hour day at our facility. Starts with labs. Usually the meat and potatoes of the day is done with all of these visits, meeting with our different members of the team, and it usually ends the day with that CT scan before we send them home. Once they are done with their evaluation day, we need to bring them to our donor review committee, and that's at the bottom of my slide here. That donor review committee is really where all of those folks, those multidisciplinary clinicians, the nephrologists, the surgeons, the nurses, the nutritionists, and the social workers sit. And those donor candidates are presented. All of their pertinent health history is presented, their CT scan is presented, and we have to make a decision as a group. Is this person who wants to donate healthy enough to donate? Or is there too much risk involved? Is there something, maybe we found that they have high blood pressure and the high blood pressure has started to affect their organs like their heart and made their heart muscle thick? Well, that's probably not okay to then have that person proceed and donate one of their kidneys, because if you remember, high blood pressure is one of the leading 2 causes of kidney failure. So we never would want to risk kidney failure in that donor if we can help it. So believe it or not, we only tend to accept about 40% of our living donor candidates here at UW. And that is a very consistent number year after year after year. We roughly only accept 40% of all those folks who come in for an evaluation. And that might seem strict, that might seem stringent, it might seem impossible to find a living donor if we're only accepting 40%. But again, the last thing we want to do is put somebody in harm's way just because they want to help save somebody else. It's a very altruistic thing to do, to want to help somebody live a longer, healthier life. But the last thing, again, we want to do is put them at potential risk of kidney failure or complications. So again, we usually only accept about 40%, and that's based on all of their testing done. All right, donation. The majority of our surgeries done at UW are done laparoscopically. And that is done through a few incisions, small incisions, and I have a slide in a little bit that'll show you where the incisions are. We always attempt to do the surgery laparoscopically first. It is a lot easier on the patient, it's a lot easier to recover from, and a lot less risk of a big open surgery with a big incision. The laparoscopic surgery tends to be about 3, maybe 4 hours long. Most of our donors at UW Hospital go home the next day, believe it or not. And we usually have that person off of work for about 4 to 6 weeks, depending on how physical their job is. If it's a desk job, well, I've had donors go back to work the next day in their hospital room working on their laptop. I never suggest that, but it does happen, unfortunately, where people are very committed to their job, and even 24 hours off of work seems to be too long for some people. There is an 8-week lifting restriction. I usually say it's 10 pounds for 8 weeks. Anything over a gallon of milk is going to be too heavy. Even though this surgery is mostly laparoscopic, there is a little bit larger incision where we do have to go take that kidney from, and I'll show you that in a minute. And that's why we say you really shouldn't lift anything heavier than 10 pounds for 8 weeks. We then schedule a post-op visit with that patient to come back to clinic, usually about 4 weeks after their discharge. And that's, of course, to check their incisions, to check their kidney function. Now, most donors long-term will recover about 25% of that loss of kidney function. So right now, I have 100% kidney function. If I gave up one of my kidneys and donated one of my kidneys, I would drop immediately to 50% kidney function of what I had previous to surgery. Long-term, meaning it could be as quick as 3 weeks, usually 3 to 6 months. We're seeing that that person does regain 25% kidney function. Believe it or not, that remaining kidney does grow a little bit in size and horsepower, if you will. It'll never grow to be a big Hulk kidney, so you're not going to have this big, massive kidney in your body, but it does grow in power and in size to about 75% total. So even though you're losing 50% function up front, long term, most people only end up losing about 25% kidney function. Longer term follow-up. We do follow our donors for 2 years here at UW. We check in with them again and ask a few questions at 6 months, 1 year, and 2 years after their donation anniversary. We also get labs, some blood work to make sure that their kidney function is good. We check their blood pressure and again, ask a couple of those questions at those time points. Now at UW, we don't follow people lifelong. We end that follow-up at 2 years, but that doesn't mean that people can't come back and ask us questions. We have donors from 20 years ago, 30 years ago, who maybe have a question, and we're always happy to answer those questions. So even though we don't technically follow our donors after 2 years, they're always donors to us, and they're always welcome to come back and ask questions or raise concerns. All right, the surgery. I promised you a picture. So the 4 X's that you see on the picture are the laparoscopic poke holes. And when I say poke hole, really is probably about a 1/2 inch, maybe a 3/4 inch poke hole or incision. That's where we put our camera so we can see inside. 2 are for our instruments so that we can work around inside. And 1 is for our gas line, believe it or not. We do blow the abdomen open with gas during the surgery. That's because if we didn't, you're squished. People are squished inside. We don't walk around like a balloon with this big cavernous space inside of us. Everything is nice and tight in there. So we do have to sort of blow open the abdomen to create a workable space. Once we get the kidney freed up and we're confident it will be as safe as possible to remove that kidney, that's when we make that larger incision down below. You'll see that sort of longer incision along the bikini line is what we call it. That's where we go up with our tool to go get the kidney. We move it inside the abdomen, our tool. We disconnect the kidney, drop it into a sterile plastic bag. Think of it kind of like a Ziploc. Seal it up, pull it down the abdomen, out the incision, and the kidney's out. We seal you up. So when we say it's done mostly laparoscopically, that's what we mean. There's 4 laparoscopic poke holes where we do the majority of the procedure, moving things around, freeing up the kidney, making sure that it is finally safe to go get the kidney, and then we do. All right, kidney matching. So if you remember all the way to the beginning of my presentation, I said we used to care a lot about the match. Do I match good enough to donate to this person? But like I said, really, if you're healthy enough and willing enough to donate, we can make it happen. The match is a little less important these days. But when we talk about the match, usually we're talking about this bottom box, the sensitivity. Antibodies. We need to make sure that the donor's antibodies aren't going to fight with the recipient's antibodies. We want to make sure there's going to be as least possible chance of rejection as possible for that recipient. Think of it like puzzle pieces. So we need to try to match as many puzzle pieces as we can between the donor and the recipient. Now, that's not the only component of matching and finding somebody who matches a recipient. That match could be age. Maybe a 19-year-old granddaughter steps up to want to donate to her 72-year-old grandmother. Well, that's fabulous, but I think most people would understand that I think we could probably find a better match for that 19-year-old's kidney and find a closer match to that 71-year-old's kidney function and what they need versus this robust 19-year-old. Kidney size is another issue that sometimes we get to see in married spouses, where maybe a husband is needing a kidney transplant and the wife wants to donate, but maybe the wife is 105 pounds and 4'11", whereas the husband is 275 pounds and 6'4". Well, that's probably not going to be enough horsepower for that recipient. So maybe we need to look at putting them into the paired exchange program, or NKR, National Kidney Registry, I mentioned earlier, to try to find a better match because of size. Now, I also said earlier that there's a lot of options. If you want to be a living donor, really we can try to make it happen, again, as long as you're healthy enough and willing enough. How you end up donating and who you end up donating to and when you end up donating is really a mixed bag of potpourri these days. And we'll talk through all of these options. Advanced donation, there's voucher donation, direct donation, compatible shares, non-directed donation. So again, lots of options. So direct donation. Obviously, this is sort of the old school. One person really donates their kidney directly to the person that they intend to. So let's say it's the spouse again. Maybe they are a good size match, maybe they're a good age match, and their puzzle pieces or the antibodies match as well. We can then say, yeah, you can donate directly to if you want to. That means that the surgery is happening the same day. The donor undergoes their operation. We get the kidney out. We tend to stack them here at UW, where the donor goes first. The recipient follows in the same operating room. The kidney tends to stay there. We clean the room, send the donor to the recovery room, bring the recipient on in, and put the kidney in. Now that's direct donation. A lot of folks choose direct donation if they can, because of that emotional connection. They love the idea that I'm giving my kidney directly to this person that I need to give it to. There's sort of that bond that happens during direct donation. Now, that doesn't mean that we can't do a lot of other options. Now, the large component of other options comes through this paired exchange, paired kidney exchange. There are a lot of options through that. So we're trying to find the best match, whether that means antibody match. Maybe the puzzle pieces didn't match that well and we're trying to find something better. Maybe the timing didn't match. Maybe the donor says, I'm a teacher and I need to donate in June. That way I have all summer to be off of work, all summer to recover before I go back to school in the fall. Well, we can do that. If the donor sets a time frame, we can pretty much make it happen. Once that donor donates, it sort of generates a golden ticket, if you will, to give to that recipient. And whenever the recipient is then ready to undergo transplantation, all they have to do is cash in the golden ticket. That could be through compatible share. That happens when maybe a pair is good enough. Maybe they've matched well enough. Maybe they're close enough in age, close enough in size. Maybe their antibody match is okay. It's not great, but it's okay. Sometimes we say, you know what? We could find you a much better match through paired kidney exchange. Why don't you guys go into the swap exchange program, paired kidney exchange, give us some time to find you a better match. That's usually what's happening here in compatible share. They are compatible, but maybe they want to see if there's something better that they could find in the paired kidney exchange program. Some people do this and they say, I'm going to give you guys 2 months to find me a better match before I say, I'm just going to pull the trigger and donate directly to you. Some people say, fine, let's give it 6 months. I'm willing to find something better because that's what the whole point of this is. So that's compatible sharing. A next big option is called voucher donation. So I alluded to this when I said that the donor donates and generates that golden ticket, if you will. That golden ticket is a voucher, and that could be a family voucher or a standard voucher. And this middle column of standard vouchers kind of going away because there's a new and improved enhanced standard voucher. Now let's say again that this spouse couple is coming in. The spouse wants to donate to their partner, but maybe they're not a good enough match. So that spouse donates because they're the teacher, they donate in June, they donate as a standard voucher donor. Once they donate, they are naming that recipient as their intended recipient, as their voucher holder. That's that golden ticket. Once that recipient says, I'm ready, the transplant center says, yep, I think you are teed up. You are ready to go for transplant. There's nothing more we need to do for you to make you as healthy as possible to get to transplant. Generate that golden ticket and wait for a match. This new enhanced standard voucher program, believe it or not, that donor can name one intended recipient that is in imminent need of a transplant and 5 family members who are not necessarily in need of a transplant, but they just want to protect their family. Maybe you have polycystic kidney disease running through your family and you want to name your children and then your siblings yourselves on that voucher. You can do that. So you can get that intended recipient to transplant, but then up to 5 of those family members have that safety net that if they ever need a transplant, somebody can turn in that golden ticket for it. That's really what the family voucher program is on the left-hand side of the screen. You can name up to 5 family members who are not necessarily expected to need a kidney. Now that usually is happening these days from non-directed donors or humanitarian altruistic donors. Somebody heard a podcast, somebody saw an episode of Grey's Anatomy and they got this idea in their head that they want to donate a kidney because I can and I think I want to help somebody in need. It's kind of rare these days to have a true humanitarian donor because of this family voucher idea. So it used to be where somebody would come in and just want to give a kidney. We'd put them in the exchange program and find a match for them. Well, nowadays that person still does that, but they can also take advantage of this family voucher program where they can name up to 5 people who may or may not ever need a kidney, just to give them sort of that safety net. So these vouchers, these golden tickets, if you will, are really exciting, and they've been kind of one of the main exciting advents in living donation in the past couple of years. So this last slide I have here is really about that non-directed donor, the person who came in and says, I don't really have anybody in particular, but I just feel like this is something that I was called to do. Again, nowadays they'd probably take advantage of the family voucher program, but people can do this. You can come in and donate one of your kidneys or a part of your liver, but again, we're not talking about that today. We're talking about kidney donation. Just because they want to, and that can really start a chain reaction around the state, around the country, of people getting kidney transplants. Remote donation is something that we also can do through the Paired Kidney Exchange program. Let's say that there's somebody in Alabama who needs a kidney transplant, but they have a niece up here in Madison or up here in Green Bay, Wisconsin. Well, that niece can come to our center, get the workup, get the evaluation, and if approved, donate either to or on behalf of their loved one down in Alabama. We call that remote donation. Just because you are states away or cities away doesn't mean that you have to necessarily travel to that same transplant center. We can do the donation here and send the kidney anywhere else. So that's remote donation. All right, how does one find a living donor? That is a great question. And really, the greatest answer to that is ask. Get out there, start the conversation, and start networking. I think people would be surprised to find how far one's network can reach. And I have a little photographic to go with that on the next slide. These are a few things we have at UW Health, so I apologize if the font is a little bit small, that really help people try to understand how to get a living donor, how to put the word out there, how to have the conversation with people, what the wording is that you should be asking people, how to write a Facebook post. Believe it or not, Facebook is a great way to get candidates to come in for you. We've had 20, 30 people sign up to be a donor for one specific person because they saw a post on Facebook. So social media, while it has its drawbacks, definitely has pros to it, and it gets the word out there pretty far and pretty quickly. Building a network, this is that photographic that I was telling you about. It is very interesting to see folks think they really don't know anybody or have friends or have far-reaching capabilities, but when they start to write it down, their family, their relatives, their friends, their neighbors, their community based on clubs or faith-based organizations or social media, you really can reach a far spectrum of people just by sitting down, plotting it out, and spreading the word. We also have something at UW which we like to call Living Donation Champion. Now, what is a champion? That is a person who's really sharing the message, being the champion for somebody so that that recipient can then sort of focus on their own health rather than focusing themselves on trying to find the living donor. So maybe this is a friend, maybe this is a spouse, maybe this is a family member who wasn't able to donate themselves or ended up being declined as a living donor. They can still help by being a living donor champion and being that person to get the word out, to champion living donation for their loved one or their friend, to try to network, to try to find that match, to try to find that potential living donor, again, so that the recipient can really focus on trying to be as healthy as they can be before transplantation. A few things that a donor champion can do. They can send emails, they can write letters, they can post on social media, they can make a video, again, probably for social media, write messages, make t-shirts, ask businesses to post flyers. So there's a lot of things that somebody could do as a champion. Just because they're ruled out to be a living donor doesn't mean that they're helpless. A few websites here. For more information about UW specifically, you're welcome to go to uwhealth.org/transplant. The application for living donation, of course, is uwhealth.org/can-I-be-a-donor. Lots of different resources out there. I'll leave these here on the slides, but I did want to finish with a great success story. So if anybody's been to our UW Health Transplant Clinic at the hospital, we have this beautiful rainbow wall, and we've had a rainbow wall for decades, but we recently created a new clinic and wanted to honor that rainbow wall. So this is our new rainbow wall. You walk into the registration area and you're sort of hit right away with this beautiful memorial and honorary to our past living donors. We place the current year's living donors' names on the wall in discs. This is the back side of the wall. It's sort of my favorite because it's just beautiful to look at and sort of mesmerizing and a little tranquil. On the front side of the wall is actually an interactive screen that you can search for donors, you can look up donors, you can read donor stories. But this is a great success story of Keith, who's on the right, donating a kidney to his friend Jeff, who's on the left. They're both doing fabulously. And it just started with spreading the word. So it can end up beautifully making new lifelong friends, connections, and we're happy to honor that at UW Health through this wall through other methods. And with that, I will leave it there.